científico del Instituto Nacional de Cáncer francés, ha tenido la amabilidad de trasladarse aquí. Fabien es una persona con múltiples compromisos, pero no obstante entendió la oportunidad y la obligación de venir y compartir con nosotros lo que el Instituto Nacional de Cáncer ha desarrollado. Lo ha desarrollado bajo la dirección de Fabien. Fabien es médico, farmacólogo, ha estado trabajando como director de los hospitales de París primero, después como director del Instituto Nacional de Cáncer en Francia, que es una iniciativa bastante distinta de la nuestra porque no tiene laboratorios centrales, sino que es una estructura esencialmente descentralizada. Así que, thank you very much, Fabien, since it's a great opportunity for us really to have this opportunity of hearing you, please.
Okay. Muchas gracias por esta invitación a presentar en Santander el estado de la organización del diagnóstico molecular en cáncer en Francia y también su futuro, especialmente gracias a mi colega y amigo Miguel Piris. I'll skip to English. That's enough. Okay, the initiative in France came from 3 national plans on the road. The first started in 2003, and in 2009, when the second cancer plan was presented by the President of the Republic, there was a measure, which was the 21st measure, to guarantee an equal access to innovation and existing treatment. Under that, to develop cancer molecular genetic hospital platforms and to expand the access to molecular testing. And there was also another measure to develop specific care management for patients with rare form of cancers or genetic predisposition, as well as for children, adolescents, and older people. So we built up the organization for genetic testing with 2 different programs dedicated to genetic testing, one for constitutional genetics with a network for genetic counseling and also for testing, another one for somatic genetics through the building of molecular genetic centers. For the first program, which was about genetic predisposition to cancer, we set up a network of genetic counseling centers, 122 sites in 83 cities in France, and they performed in 2012 44,000 oncogenetic consultations. Linked to these genetic centers, a network of laboratories with almost 60,000 oncogenetic tests performed during the same year, and which is moving forward now with the implementation with targeted next generation sequencing platforms. So at this time, we know that during the last 10 years, about 15,000 patients with BRCA1 or BRCA2 mutations were identified, and almost 6,000 patients with MMR mutations also. As you can see here, there is an increase, a regular increase in the number of consultations, especially for breast and ovary syndromes, and probably which is less developed, and we will have to focus during the next years, during the third plan, for colorectal cancers. Not enough, as you can see here. It's still less than expected. We also set up an organization of molecular centers for personalized medicine. Really, the objective initially was to perform molecular testing for all the patients in France, to do it free of charge, whatever the healthcare institution status was, public or private, to perform high-quality tests for leukemias and solid tumors. So this was based on a regional organization. We have 26 regions in France, and we set up 28 regional centers because Paris is three regions by itself. So it was a partnership between different laboratories located in university hospitals or cancer centers. And in each of these centers, there should be a cooperation between the pathologist and the biologist. That was the main difficulty, in fact, but it worked. So we went from these somatic genetic centers to personalized therapy, and we did that according to the expansion of the portfolio of new drugs. And as you can see here, when BCR-ABL translocation and imatinib, dasatinib, and nilotinib were on the market, all the centers of the platforms were ready to perform the tests. That was the same for GI, for GIST, with KIT and PGF receptor mutations, for HER2 amplifications in breast cancer, then in gastric cancer, KRAS mutations for colorectal cancers, EGFR mutations for lung cancer, ALK translocation, and BRAF, obviously, more recently. And as you can see here, the number of tests reached, almost 65,000 patients could be tested in 2012 in France. I would like to give you something which convinced the authorities that it should be useful to do this test according to the economics. I would like to take an example, the example of gefitinib treatment, and we demonstrate through this example that it has an acceptable cost for the health insurance system. The cost of EGFR testing for lung cancer patients, that means it's almost 17,000 patients, is 1.7 million euro. This allows to identify 1,700 patients which were positive for mutation. And the cost of the treatment was estimated according to the work by the initial work by Mogg, that the median survival time should be 38 weeks, and the cost should be 35 million euro. Performing the test allows you not to treat 15,000 patients who should be treated otherwise at least 8 weeks, that means 2 treatments, for 69 million euros, that the spared cost of gefitinib treatment is almost 70 million euros. So this convinced the authorities that we should do that. So at this point, all these tests are performed in these platforms. We expect that all the patients who deserve to have these tests for a specific treatment got it. And we are now engaged in the last 3 or 4 years in a program for prospective detection of emerging biomarkers. That's you have a list of some of them in these: EGFR, KRAS, HER2, PI3 kinase, BRAF, ALK, KIT, and so on. And the platforms are really ready in advance to perform the test as soon as the therapy is available. So there is an increasing number of actionable molecular alteration, as you all know. This number is increasing regularly, and it will change our consideration of what are the cancers. And at this point, we are moving to the implementation of targeted NGS for diagnostic in these 28 molecular genetic centers. Targeted sequencing on gene panels, and call for proposal to grant a selection of pilot projects. The objective at this point, and this objective is written in the cancer plan, which was recently presented by President Hollande, is to perform targeted NGS for 60,000 patients by the end of 2016. I would like to show you some work which has been done by a group of a cooperative group that we have launched, which the name of this group is IFCT for thoracic cancers, and they have performed a survey through the platforms of what's happening in these patients with lung adenos. This is a preliminary presentation that was done at the ASCO last year. Almost 10,000 patients. You have the demographics, which are here. The analysis of the sample collection, the delay between collection and analysis, and the delay between start of analysis and results. And we were quite happy about this delay, which is at 11 days, as you can see here. So that the results on almost 10,000 patients, as you can see here, EGFR mutations are represented in the real life, you can say that. Almost 10% of the patients, KRAS mutation, 27%. EGFR-resistant mutations in almost 1% of patients, HER2 mutations, 1%, BRAF, PI3 kinase, ALK rearrangement in 3.7% of the patients. In almost half of the patients, there is no biomarker assessment leading to therapy. When a sub-analysis was performed according to smoking or non-smoking habits, and as you can see here, we have a clear survey in a large number of patients of the mutations and molecular alterations encountered, for instance, in non-smokers on the right panel. And this was one of the questions to the clinicians who send us the specimen from their patients. Does this help you in guiding your therapy? And as you can expect, almost 57% of the patients could have a decision based on these data. And we could also have a survey of the survival of the global population analysis during this work, and you have these curves on this slide. So there is an increasing number of actionable molecular alteration, and there will be more and more in the following years. When you consider the patient, the global analysis of what can be found in the different type of cancers, you see that apart from P53 and RAS mutations is a confounding problem, but you have also a lot of mutations that could be targetable in the next years. So what we really want is really to go forward at this point and to implement the use of next generation sequencing for clinical use, and to do that in a coordinated way in the 28 molecular genetic centers. So the implementation is ongoing with a panel of genes, and we will have to go forward with probably exome sequencing as it is previously projected in the future in this cancer plan, which started in 2014. So we launched for this. We did as we did before for the unique test. We made a call for proposals for the NGS organization for diagnostics and care purposes. The main objective was really to prepare the use of NGS for diagnostic, both for constitutional oncogenetics and in molecular genetic centers, and to do that through a pilot phase in a limited number of laboratories. So we made 3 sub-calls, one for the implementation of NGS in labs, a second sub-call to support bioinformatics reference teams, and the third one to estimate the economic impact of doing so. The objective was to go forward for the structuration in cities or region, to optimize the resources among these labs and paying a close attention to the quality control, to join a national coordination network allowing the exchange of practices through a monitoring group which is led by INCAM, and to use NGS for routine practice at the end of this project. The perspective, as I told you, for us it's exome sequencing. The cost will be decreasing and decreasing, so probably it will be worthwhile doing exome sequencing in the next 4 to 5 years for all the patients. I'm not sure about that, but we are on this. We are going on this direction. The key points for success being the optimal quality of samples, operational NGS sequencing platform in a limited number of cities, identifying structures for the storage of large volume of data, to optimize pipelines for NGS data analysis and qualified dedicated staff, and also to organize the medical decision support tools and specific organization to help clinicians optimizing the use of NGS results. Because obviously, it will be more and more complicated in the next years. We expect that probably in 2019, we will have more than 50 drugs targeting specific abnormalities. So it will be very complicated to have to make the decision to use such or such drug and such drug in combinations, obviously. So we will have also we will need also a national database for the integration of clinical and molecular data, and we will have to consider during this time lapse the specific constraints, legal constraints, quality of diagnostic, and all the ethical issues raised by these discoveries. So I would like to tell you that when we started that, we had in mind that the clinical work has to go forward at the same speed. And that's one of our goals, is really to make for the authorities, the social system and so on, you have to prove that it's useful to have these molecularly guided therapies that we are entering. So we have the need to demonstrate that NGS, exome sequencing, is of interest for treatment decision. And for this, we are launching, we have started already, national cooperative randomized studies in early metastatic patients. It's written in 3 tumor types, but I should say 4 at this point, because we want to address metastatic breast cancer, lung carcinoma, colorectal cancers, and sarcomas. And the idea is really to make this demonstration, to go through a randomized study, as it is described here for the SAPHIR-2 projects. There is SAPHIR-2, which is on metastatic HER2 negative breast cancers. And you have here the scheme of the trial and the time where randomization occur. Between arm A, targeted therapy according to the molecular alteration. Arm B, best available therapy, not based on molecular alteration. So 2 of these projects have already started, one led by Fabrice André on breast cancer, and one led by Jean-Charles Soria for lung carcinoma. So for these protocols, at least 3,000 exomes will be analyzed. And this is a project in partnership with the French Ministry of Health, the 28 molecular genetic centers, and the 8 comprehensive cancer centers we have launched in France through public and private sequencing structures and bioinformatics resources, private or public. And also, which was a fight, and I believe that we have gained on that, it's the participation of different companies to provide us their drugs, which are in phase 1 or phase 2 trial, to be put on a same bag and used for these protocols. So it's also the opportunity to assess the financial impact of NGS, evaluate the needs for training doctors and for human resources, to evaluate the medical, scientific, economical, and industrial benefits of NGS in clinics, and also to validate, to make the translation from clinics to biology, validate targets, develop experimental models, develop proteomics and metabonomics. And that's it. Thank you very much for your attention.